Clostridium difficile is an absolute scourge of modern medicine. It's one of the most common healthcare-associated infections. On top of that, it's incredibly difficult to treat and prone to complications and recurrences despite appropriate treatment. And on top of all of that, it affects the most vulnerable groups of patients. As I'm sure you know, it's closely linked to the overuse of broad-spectrum antibiotics. You don't have to know a lot about the pathophysiology of this infection. The basic principle is pretty straightforward. First, a broad-spectrum antibiotic wipes out the patient's gut microbiome, and the bacteria that are left are now free to multiply and take over the niche. Naturally, these bacteria tend to be more resistant to antibiotics, that's why they didn't get wiped out in the first place. Clostridium difficile is particularly prone to do this since this bacterium is intrinsically resistant to many antibiotics, and on top of that, it has the ability to form spores, dormant, metabolically inactive structures that are impervious to antibiotics and even most disinfectants. They are basically indestructible. They just wait until the right circumstances set in, then they reactivate and start to multiply, and there you have it. This is the basic pathophysiology of Clostridium difficile-induced diarrhea. So, two events are crucial for the development of this infection. Number one, the patient's gut has to become colonized with this bug, which means the patient has to ingest the spores. And number two, the patient's gut microbiome has to be significantly damaged, disrupted, usually by broad-spectrum antibiotics or chemotherapy. With that in mind, it's not difficult to figure out what we need to do to prevent this infection, or at least significantly reduce the likelihood of occurrence. There are steps you can take right now, there are ones that will take a little bit more time and effort, and there are some that are still a little bit speculative, so let's go through them. First, antibiotics. This is why I do what I do. This is why I make these lectures. The choice of antibiotics matters a lot, and the consequences, both positive or negative, are immediate and often dramatic. Anyone can prescribe meropenem plus vancomycin plus 2 other antibiotics and hope for the best. But if you know what you are doing, and it doesn't take a lot, you can make much better choices where you reliably cover whatever infection your patient has, and you make sure that you don't wipe out their microbiome or overwhelm their kidneys. This can all be learned, and it's not rocket science. If you've seen my videos, I'm sure you already know about my online courses on antibiotics in clinical practice, and you know that the link is in the description. A few hours of structured lessons are enough to master the logic of the most commonly used antibiotics once and for all, and this is enough for you to learn how to recognize and treat the most common and the most severe infections with confidence. This is essential knowledge for any acute care clinician. A narrow-spectrum antibiotic is often equally effective, if not more effective, than the one with insanely broad spectrum, and it's far less likely to lead to Clostridium difficile diarrhea, development of resistance, and many other unwanted consequences. Okay, so much about antibiotics. What about the other half of the story? How do we make sure that our patient doesn't get colonized by Clostridium difficile? Well, this part is a bit trickier. It's easy in principle, but in practice it requires discipline, consistency, and clear rules that everyone will follow. So, let's go through a few key points. If you already have a patient in your ward who is infected, make sure that they don't come into contact, either direct or indirect, with other patients. A patient with Clostridium difficile diarrhea will shed enormous amounts of this bacterium in stool. Let's not forget that Clostridium difficile forms spores, dormant forms that can survive even on inanimate objects for weeks, if not months, which means that the patient's skin, their clothes, their bed, the objects around them, the toilet in their room, everything is covered in this bacterium. So what do? Here is an exercise I find immensely helpful. Imagine that your patient is covered in thick, poisonous paint that will not get dry for months. Everything they touch will get painted. If you make physical contact, your hands will be covered in paint. Even your scrubs, your stethoscope, nothing is immune to this paint. And then, if you go on to the next patient, this paint will end up on them, and before you know it, the entire ward will be covered in this poisonous paint. and at that point it will be impossible to clean up, right? So, how do you make sure that this doesn't happen? For starters, it would be great if your patient could be placed into a single room. That way, they are much less likely to come into contact with other patients, either directly or indirectly through shared objects, toilets, doorknobs, or anything. If a single room is not possible, at least make sure that all patients with Clostridium difficile are not placed in the same room as uninfected patients. Next, we still need to treat our patients, which means we will have to make physical contact with them and their surroundings. So how do we do that and make sure that we then don't get covered in this invisible paint? I know it sounds silly, but seriously, keep that image in mind and you will know what to do. Just because you don't see the paint doesn't mean that it isn't there. To make sure that it doesn't end up on your hands, it's a good idea to put on gloves the minute you enter the patient's room. But here's the thing. Wearing gloves in itself is not enough, and it certainly does not replace hand hygiene. I cannot emphasize this enough. Here's what drives me nuts in hospitals. When a member of the staff enters the room and goes straight to the glove container without washing or disinfecting their hands first. I'm aware I might sound like an obsessive, germophobic, infectious diseases geek, but in a hospital ward, you have to be a little obsessive, especially when you are dealing with dangerous pathogens. Because here's the thing. Clostridium is just one type of poisonous invisible paint, right? Your hands are covered in many more colors, in many more bacteria. If you touched a keyboard, it's basically like touching a toilet bowl at a train station. If you touched a doorknob, same thing. Your phone. How many hundreds of times have you touched your phone? And I could go on and on. And now, if you go straight for the glove container without disinfecting your hands, you've probably contaminated that container with all these bacteria from your unwashed hands. So everyone who takes another pair of gloves from that container is likely to contaminate their hands with the same bacteria, and with that, they will contaminate the patient or their surroundings. So remember, wash or disinfect your hands before you put on gloves, and wash your hands after you remove them. Because when you're removing the gloves, you will inevitably contaminate your hands. That's not even up for debate. So, wash your hands afterwards. So yes, when you're coming into direct contact with a patient who is infected with Clostridium difficile, gloves are useful and necessary. But without good hand hygiene, they are useless, and if you use them as a substitute for hand washing, they do more harm than good. So, gloves plus hand washing. Okay, so much for your hands. What about your scrubs, your stethoscope, blood pressure cuffs, and all of that? Well, when approaching a patient with Clostridium difficile, you should wear a disposable gown. And obviously, you should dispose of it before you move on to the next patient. It will be covered in paint. It will be covered in Clostridium difficile inevitably. And stethoscopes and cuffs, it would be ideal if you used a dedicated stethoscope for this one patient. This is what we do in my ward, in my ICU. I know this might seem excessive if you are not used to it, but with pathogens like Clostridium difficile, it's absolutely necessary. A few more things about hand hygiene specifically. Alcohol-based disinfectants are easier and quicker to use than hand washing, that's for sure. And this is a major advantage because the main obstacle in hand hygiene in hospitals is compliance. We all have to wash our hands hundreds of times a day, and it becomes cumbersome after a while. So something that is quicker and easier is more likely to be adhered to. However, with Clostridium difficile specifically, there is a problem. Its spores are resistant to most disinfectants, including alcohol. So here, hand washing with soap and rinsing with water is superior to alcohol disinfection. Also, when disinfecting patients' surroundings, the choice of disinfectants matters for the same reason. Many disinfectants are simply not effective against Clostridium difficile. And let's not forget that once a patient with Clostridium difficile is discharged, the room should be thoroughly disinfected before admitting the next patient. Remember, the spores can survive on inanimate objects for months, and as long as they are there, they pose a risk to the next patient. As you can see, the contact precautions I explained here are really not difficult to grasp, especially if you keep reminding yourself about the invisible paint, right? The main obstacle is compliance, discipline. So, now that you know what to do and why it matters, I encourage you to educate your colleagues and coworkers. These measures are not spectacular or highlight worthy, but they are essential and life saving. Okay, is there anything else we can do to prevent the spread of Clostridium difficile besides a good antibiotic policy, contact precautions, and cohorting? I'm sure you've heard about probiotics. Do they work? Well, based on the available information, generally, no. If you ask me, this actually makes sense. Once a broad spectrum antibiotic wipes out a balanced, intricate, and diverse system like the gut microbiome, why would introducing a single species of bacteria suddenly fix it? It's like firebombing a forest and then expecting it to recover completely and immediately if you reintroduce rabbits or mice. It simply doesn't make much sense, does it? There are other interventions that are more plausible but still not defined well enough, like giving certain high-risk patients a prophylactic dose of oral vancomycin, which is used to treat Clostridium difficile, right? In certain groups of patients, this can indeed reduce the likelihood of Clostridium difficile-induced diarrhea, but good antimicrobial policy and contact precautions that everyone adheres to are essential, and they are the core principles of preventing the spread of Clostridium difficile. Visualize the paint and you will know what to do. And as for antibiotics, if you want to truly master them, I recommend you follow the link in the description. You will understand right away why this system works so well. Take care.